Thank you for giving me this opportunity. So I'm a Dr. Raghu Kishore Galla. So I'm a practicing consultant interventional cardiologist in KIMS Hospital. Currently I'm pursuing a postgraduate course in heart failure in the University of Zurich, Switzerland. So I'm specifically interested in heart failure. So I'm presenting a brief case of heart failure, so which turned from ventricular ectopy to heart failure, so which has a long follow-up. So a 50-year, so I should thank Dr. Raghu Garu, our electrophysiologist, who has been following up this patient for the last 10 years. A 52-year-old surgeon from Patna, Bihar, was referred to our hospital for evaluation of heart failure. The past history was, in 2012, he had recurrent episodes of palpitations, no ECG documented arrhythmia, Holter showed NSVT, echo showed normal LV function, and CT CAG showed myocardial bridging, and he was treated with beta blockers. Further, in December 2016, he developed dyspnea on effort, increasing symptoms with paroxysmal occult dyspnea and orthopnea. ECG showed same morphology of ectopy, that is RBBB, and ectopy is also of same morphology. Echo was showing akinetic inferior wall, anterior wall, and moderate to severe LV dysfunction. Coronary angiogram was done in 2017 April, showed normal coronaries, and he was initiated on heart failure medications. So this was the ECG, it was old ECG, so which was not clear. So showing baseline RBBB and ectopics, few ventricular ectopics, QRS notching, and QS in inferior leads. So cardiac MRI was done in KIMS Hospital in 2017. So there was thinning in apical mid and basal inferior wall. EF was 24%, and transmural enhancement of the inferior wall, mid myocardial focal LGE, basal inferior and antiseptal involvement, and large mediastinal lymph node. Next day, PET scan was performed. It was showing abnormal focal metabolic activity in the distal lateral wall and apex, and hypermetabolic mediastinal lymph nodes, and no activity in the peripheral lymph nodes. So coming to the diagnosis, so we have suspected granulomatous cardiomyopathy, so mostly sarcoidosis versus tuberculosis. Thoracoscopic guided VAT guided lymph node biopsy was done for mediastinum, mediastinal lymph node. Non-casitating granuloma was demonstrated with haploid cells, and Langhans giant cells was also seen. Interferon gamma release assay was positive for tuberculosis. Gene expert was negative, TB culture was negative, and Monto test was positive. So again, we were in dilemma, so whether it is tuberculosis or sarcoid. So we named it as mixed sarcoid tuberculosis because wherever the endemic is tuberculosis, so before you start immunosuppression, so you have to make sure that it is not tuberculosis, otherwise it may disseminate. So we have started immunosuppression with the steroids under the cover of ATT, and meanwhile heart failure therapy was escalated. He was put on single chamber ICD in June 2018 for primary prevention of sudden cardiac death. 2018 to 21, he was all right. He was doing well, no symptoms, no ICD shocks. He was on low dose maintenance therapy on steroids, prednisolone 7.5 mg. LVEF improved to 38%. Repeated PET CT was showing no FDG uptake. Device logs until March 2021, 0.1% ICD ventricular pacing at 40 beats per minute. And in July 2021, after 3 months regular follow-up, there was 1.1% of ventricular pacing, and lower rate limit is increased to 60. He began to have intermittent episodes of severe shortness of breath and orthopnea since Jan 2021. Typically, episodes correlated with the ventricular pace rhythm at program lower rate, and LVEF in January was 30%. Again, we repeated PET scan. It was showing metabolically active disease and increased uptake in papillary muscle, cardiac apex, LV and RV myocardium. Escalated the steroid dose and added azathioprine and HCQs. Started on adalimumab, 40 mg subcutaneous. After 2 doses, he landed in congestive cardiac failure, so that it was stopped. In August 2021, he was started on tacrolimus. He used for 10 days. Again, he discontinued due to palpitations. In the latter half of 2021, the patient was on steroids and mycophenolate mofetil, that is 1000 mg BD. Then in November 21, again he came with the symptoms of heart failure. He was admitted in congestive cardiac failure, class 4, with dyspnea and pulmonary edema. Heart failure, this time is complicated by hypotension and oliguric AKI. ABG was showing mild acidosis with lactate 6.4 millimoles per liter. Creatinine rise to 1.5. NT-proBNP was 14,000, and 2D showed global hypokinesia with EF 28%, severe MR and RV dysfunction. So this was the ECG in 2021. So it was showing complete heart block with ICD backup pacing, 100% ICD backup pacing. So you can see whenever there is QRS preceded by P wave, there is increase in the blood pressure. So demonstrating the importance of AV association. And he was treated in ICU, managed with diuretics, inotropes, dobutamine, NIV support. Oral steroids were escalated to IV steroids. ICD device interrogation has showed multiple episodes of complete heart block and 100% ventricular pacing. Repeated PET scan, this is a picture, the background picture is a repeated PET scan which showed metabolically active disease in the myocardium. So what could be the next step of the management? So whether to escalate immunosuppression and heart failure medications, upgrade to dual chamber ICD as it is showing that AV association is very important, upgrade to CRTD plus optimization of immunosuppression and GDMT or heart transplantation. So
heart transplant.
So we can consider heart transplantation, but before that, we have considered CRTD, upgradation to the CRTD because of 100% backup pacing. He was needing pacing. So after CRTD, so this was the ECG. So multiple morphologies of VPCs or VT went to work up for sarcoid or tuberculosis. So VPCs with multiple morphologies, pleomorphic VT, VPCs of LV myocardial origin, VPCs where pattern recognition therapy like RVOTV or fascicular or pretesticular is unlikely. ECG showing conduction abnormalities like RBBB, prolonged PR, fractionated or notched QRS, you should suspect granulomatous or infiltrative cardiomyopathy. When to put an ICD, so as all of you know, class 1 is spontaneous sustained ventricular arrhythmia or prior cardiac arrest or LVEF less than 35%. Despite of the optimal medical therapy and immunosuppression therapy. ICD can be useful when there is an indication for permanent pacemaker and unexplained syncope or near syncope felt to be arrhythmic origin or inducible ventricular arrhythmia on EP study for more than 30 seconds. So if you are skeptical of putting an ICD, so cardiac CMR is very, very useful. If there is no LGE, so ICD is not recommended. When to upgrade it to CRT? When the patient's LVEF less than 35%, left bundle branch block QRS duration more than 150 milliseconds, NYHA class 2 or 3, or if pacing indicated and expected percent of pacing is more than 40%, you can upgrade the ICD to the CRTD. So the take-home message today from our case is to consider diagnosis of granulomatous heart disease in patients with new onset heart failure, VT or both. Systematic follow-up for recurrences because he was asymptomatic almost for 3 years with even PET scan was negative, but after that again it was recurred. Upgrade the device according to the need. So he was needing 100% ICD backup pacing, so that we have upgraded to CRTD. Team approach in the management like pathologist, radiology, nuclear medicine specialist, pulmonologist, immunologist, if necessary, HLT, heart-lung transplant. Then importance of AV synchrony in patients with heart failure. Thank you.